Hello, everyone, and welcome to day 2 of the 10th Annual Microbiology Virtual Event Series brought to you by LabRoots. Today's keynote presentation is titled Bacterial Vaginosis, New Insights from the Vaginal Microbiome. I am Israel Gonzalez of LabRoots, and I'll be your moderator for. As a reminder to our audience, we encourage you to chat with your peers using the group chat window on your screen. And you can also submit questions using the question submission button below for our speaker to answer live in the Q&A segment just after the presentation's finished. Also, if you have any trouble seeing or hearing the presentation, please click on the help button located in the navigation bar found in the event space. Well, let's go ahead and get started here. I now present today's speaker, Dr. Susan Tuddenham, Assistant Professor, Infectious Disease at Johns Hopkins Department of Medicine. To view Susan's complete biography, please visit the presenter window. Susan, I do see that the slides are moving, so you're good to go. Unfortunately, we don't have Susan on camera with us today, but that's all right. We have her voice. And now, Susan, you may now begin your presentation.
Well, thank you so much, and I'm so pleased to be here to speak to you about bacterial vaginosis, new insights from the vaginal microbiome. And I do apologize for our technical difficulties this morning. These are my disclosures and acknowledgments, and I did want to pause for a moment before we go further and say that we're discussing the vaginal microbiome today, but of course not all people with vaginas and hence a vaginal microbiome will identify as women. So I'll try to use language inclusive of this reality, but if I use cis woman-centric language, it's for ease of discussion or because of the language used in the research cited, and it is truly not intended as an erasure for other important demographics. So I realize that most people in this audience are probably not clinicians, but I wanted to start out with a clinical case just to illustrate to you how this problem impacts people in the real world. So this is a 26-year-old cisgender woman who's coming into, we'll say, my clinic. I see many of these individuals complaining of recurrent vaginal symptoms, including of odor and increased vaginal discharge. Never had problems until about 2 years ago when she became sexually active with a new partner and actually has now been monogamous for a very long time with her current male partner, but has been having episodes of vaginal odor and discharge recently nearly every month. She's had STI testing, including for gonorrhea, chlamydia, trichomonas, syphilis, and HIV many times, which has all been negative. And she gets medications for these episodes. The symptoms do go away when she's taking the medications, but especially lately, she feels like there are sometimes when almost as soon as the medication's finished, the symptoms seem to start up again. So it's having a major impact on her relationship, on her self-esteem. It's really, really bothering her. And the question is, what's going on with this patient? Well, the patient consents to pelvic exam, and on exam, she has a thin, homogeneous white vaginal discharge, and this is an image here of the cervix with some discharge in the picture on the left. The vaginal pH is elevated, greater than 4.5, and she has clue cells greater than 20% of epithelial cells on microscopy. So it might be a little hard to see here, but in the center of this screen in the picture on the right, there's a clue cell, which is a vaginal epithelial cell essentially covered by a mat of bacteria. And then she has a positive amine or whiff test, which is a pretty low-tech test that clinicians use where they essentially put KOH onto a vaginal swab and sniff it to see if there's a fishy or amine odor. So she has all 4 of these things, and these things, by the way, are called the Amsel's criteria. If you have 3 of those 4, you can be diagnosed with bacterial vaginosis. So no surprise from the title of this talk, but the problem this patient is encountering is bacterial vaginosis, or BV. Now, the patient has a lot of questions, as you may as well, and these include, what is bacterial vaginosis, or BV? Why does it keep recurring? And most importantly, what can I do to stop it? So we'll talk a lot more about this, but I think what we're starting to learn with new research is that BV does appear to be a disorder of the vaginal microbiome, by which I mean a disorder of the communities primarily of bacteria that are colonizing the vagina. I think it's pretty interesting from that perspective because in research and in medicine, we hear a lot about the human microbiome, whether it's the gut microbiome, the vaginal microbiome or the microbiome of another anatomic site. But if you think about it, there are very few conditions that truly have been found to be a disorder of a human microbiome at a particular anatomic site. I think BV is probably the only one I can really think of that is that. And so as a prototype entity, it's pretty interesting from that perspective. So this talk is going to be fairly general. We're going to focus on bacterial vaginosis and what we are learning about this condition based on studies focused on the vaginal microbiome and the vaginal microenvironment. So hopefully by the end of this presentation, you'll be able to identify BV and its relationship to the vaginal microbiome, at least based on current knowledge and definitions. And I will say that there's a lot that's not known. So in the spirit of that lack of knowledge, you'll also be able to identify some key questions in the pathogenesis of BV and recurrent BV, and then identify some possible future directions in treating and preventing BV, because as you can see from this example patient, our currently available treatments are just not as effective as we would like. This patient is having multiple recurrences despite our treatments. So a little bit more about BV and recurrent BV epidemiology. BV is the most common cause of vaginal complaints in women of reproductive age. It affects a very large proportion of women, including in the United States. And treatment is recommended for those with symptoms. First-line treatment is an antibiotic called metronidazole that can be given by mouth or vagina, or an antibiotic called clindamycin that can be given by vagina. But despite these antibiotics, nearly 30% will recur within a month and 60% within 12 months. So again, these treatments are really not as effective as we would like, at least in the long term. And there's a subset of patients who have symptomatic recurrent BV who may be recurring repeatedly, and it seems like relentlessly, like our example patient. So BV is a big problem for people, number one, because of the morbidity associated. So it again, is the very common cause of vaginal symptoms, including discharge and malodor in reproductive age women. But whether or not people have symptoms, and about 50% of people with BV have symptoms, it's associated with an increased risk of acquisition of a variety of sexually transmitted infections, including HIV, as well as pelvic inflammatory disease and some adverse obstetric outcomes such as preterm birth. So BV is a problem for many reasons. Now, let's talk a little bit more about the vaginal microbiome. Today, we're going to be discussing the relationship between BV and the vaginal microbiome. And just in terms of definitions, when I talk today about the vaginal microbiome, I'm really going to be referring to the communities of bacteria that are inhabiting the vagina. But remember, there's also a virome, a mycobiome, so fungi, and perhaps even a parasitome. Those areas are just not as well researched, however. And so today when I talk about the vaginal microbiome, I will be talking about essentially the communities of bacteria inhabiting the vagina. Now, in the optimal state, we're starting to learn that the vaginal microbiome seems to be dominated by a few lactobacillus species. And these are bacteria which, as their name suggests, produce something called lactic acid, which acidifies the vaginal microenvironment, and we think is really healthy and protective, including against invading pathogens, things like sexually transmitted infections like gonorrhea, chlamydia, HIV, etc. And there are probably multiple mechanisms by which lactobacilli are protective for women's reproductive health, certainly through the action of lactic acid and the low pH that's created in the vagina. Lactic acid has been shown in vitro to inhibit the growth or proliferation of pathogens such as gonorrhea, for example. These lactobacilli may do other things that are protective as well, including competitive binding to vaginal epithelial cells, so other pathogens can't bind. They may produce things like bacteriocins or have immunomodulatory effects, helping to tamp down inflammation in the urogenital tract, which may be very, very important, for example, in helping to prevent HIV. So we think of the vaginal microbiota in that optimal state as the body's first line of defense against invading pathogens, things like sexually transmitted infections that would like to cause trouble. Now, for reasons we don't entirely understand, in some individuals, those vaginal lactobacilli are decreased, and instead there is a presence of a variety of gram-negatives and anaerobes, things like Gardnerella vaginalis, Prevotella, Mobiluncus, Adipobium, Smithia, variety of BV-associated bacteria. And we call that condition with low lactobacilli and an increase in these other organisms, bacterial vaginosis. The vaginal pH in those individuals tends to be elevated and vaginal lactic acid is lower. Now, BV diagnosis, we already mentioned how we tend to diagnose it in the clinic via Amsel's criteria. You can also diagnose BV via gram stain, looking at the different morphotypes of bacteria present on a gram stain of vaginal secretions, essentially looking at lactobacilli relative to these other BV-associated bacteria. There are also direct point-of-care tests that are enzymatic based on, for example, detection of sialidase, which may be produced by BV-associated bacteria. And then increasingly commercially available and popular amongst clinicians are molecular tests for BV, which each one of those is sort of a proprietary formula and has its own methodology, but they tend to be probes looking for a variety of these different BV bacteria and sometimes also looking for lactobacilli and the ratio between those two. Now, prior to about 10 or 15 years ago, most of the research on bacterial vaginosis as well as the vaginal microbiome really relied on culture-based techniques. But many of the bacteria that are present in the vagina are anaerobic. They may be fastidious and difficult to grow in the lab. And so it's really with the advent of these new molecular techniques that we've been able to get a much more detailed and specific look at the bacteria that are present in the vaginal microbiome and in what relationship in terms of relative abundance they are to each other. So one of the first insights, and most of this early research was based on 16S RNA gene sequencing, although now we're increasingly moving to, say, metagenomic techniques and other molecular methods. But much of this early research was done with 16S. So one of the first insights actually from my colleagues over at University of Maryland, published all the way back in 2011, was that the vaginal microbiome of reproductive age women could be grouped into what they termed community state types, or CSTs, based on composition and relative abundance of particular bacteria. And they found that there were at least 5 CSTs, and 4 of those were dominated by different kinds of lactobacilli. So CST1, for example, that you can see in this table here, was dominated by Lactobacillus crispatus, and CST3 by Lactobacillus iners, whereas CST4 was characterized by having a relative lack of lactobacilli and was high in a variety of those other BV-associated bacteria. But I think one of the other central pieces of information or central insights that's come out of this vaginal microbiome research is that not every woman with BV has the same vaginal microbiome. So even if you just group these sort of in large categories, you can see here they're grouping into CST4A, B, and C based on different bacteria, and even more granular groupings are possible. So I think, again, one of the important insights here is that not all women with BV have the same vaginal microbiome, although we sort of treat them all the same, just with the same antibiotics. Now, with this new research on the vaginal microbiome, we've also started to understand more about those sort of beneficial, optimal, healthy bacteria that are present when people don't have BV, those lactobacilli. And I think one of the insights that has come out of this research is that not all lactobacilli are equally helpful and protective. And some of that may relate to the metabolites they produce, particularly lactic acid, which I had already mentioned is important and healthy, but not only lactic acid, but actually the isomer of lactic acid they produce. And so we found in multiple epidemiologic studies that Lactobacillus crispatus in particular seems to be very protective against things like acquisition of sexually transmitted infections, whereas Lactobacillus iners is not as protective. And perhaps some of that relates to their ability to produce D-lactic acid. So Lactobacillus crispatus, as you can see from some in vitro work, this is a table from some in vitro work, essentially is very able to produce both D and L lactic acid, whereas L iners really doesn't produce D-lactate at all. Now, I think another important insight from the vaginal microbiome research has been into what is actually causing the symptoms of BV, what's involved with the pathogenesis of BV, because it's not just obviously the composition of the vaginal microbiome that is affecting patients. It's really what are those bacteria doing in terms of interacting with the host, and also critically, what are they producing? So we mentioned lactic acid produced by lactobacilli, something that's healthy, but BV-associated bacteria may produce a variety of metabolites as well. And as an example, I mentioned that vaginal odor is a central complaint of many women with bacterial vaginosis. And it's actually a component of our diagnosis as well, because with that very low-tech whiff test, where essentially the clinician is sniffing the vaginal swab, that's one of the main criteria for diagnosis of BV. And so what we've learned from metabolomic studies of vaginal secretions is that certain biogenic amines, certain compounds that we think are produced by many of these BV-associated bacteria, are associated with symptoms like odor. And so, for example, here you can see a interestingly named biogenic amine, putrescine, is associated with this amine or fishy odor. There is a lot of other complexity to our research on BV-associated bacteria, the vaginal microbiome in BV, and how these bacteria are interacting with the host, how that's important in terms both of symptoms and of pathogenesis, including of sort of difficulty with recurrent BV. I'll just mention that there is a layer of cervical vaginal mucus which forms a protective layer above the vaginal epithelium in the healthy vagina. And that serves a lot of different purposes, including sort of protecting against invading pathogens, as well as keeping that mucosal barrier intact. Now, several BV-associated bacteria have been found to produce enzymes such as sialidases, as well as some other enzymes, that probably play a number of critical roles in virulence and pathogenesis, among them their ability to help with degradation of that mucus layer, as well as their ability then to enhance attachment of those BV-associated bacteria to vaginal epithelial cells. There are also questions about whether this is a mechanism by which BV-associated bacteria may be able to form biofilms. Now, I will say that whether or not a biofilm exists in BV is highly controversial. I think people don't agree on that, but nonetheless, that is one of the hypotheses. And also degrading that mucus then perhaps enhances the action of other substances that are produced by these BV-associated bacteria, including cytotoxins such as vaginal lysine, which may be toxic to vaginal epithelial cells and play a role in BV pathogenesis. And then, as I mentioned, these sialidases actually can be exploited for diagnosis as well, and that's one of the methodologies behind rapid tests for BV. So sort of summarizing what we've talked about so far, but really going back to the patient's questions to summarize these items. When she asks, and we ask, what is bacterial vaginosis? Well, we do think it's a disorder of the vaginal microbiome, and we think it's characterized by a lack of lactobacilli or a relative lack of lactobacilli and the presence of a variety of BV-associated bacteria. But defining what BV is beyond that is pretty difficult, and I think one of the key difficulties is that BV is not monolithic, so not every woman with BV has the exact same vaginal microbiome. I think other things that we've learned are that metabolites produced by BV-associated bacteria, like those biogenic amines I mentioned, play a key role in BV symptoms like odor, as well as potentially in diagnosis, and then host bacterial interactions, including through enzymes produced by these bacteria, are very important in pathogenesis. So that's sort of what we know so far. In many ways, more questions than there are answers, but that's what we know. And then the patient, of course, has questions about why does it keep recurring and what can I do to stop it? And these, of course, are the million-dollar questions that we don't have very satisfying answers to, at least not yet. So in terms of recurrence, there are a number of factors that are associated with BV as well as with BV recurrence in large epidemiologic studies, and those include having new or multiple male partners, although I will also say that having the same male partner can be associated with recurrent BV, or having a female partner with symptoms. And so since women, before they become sexually active, really don't get BV, this does raise the question if there is some aspect of sexual transmission of some of these bacteria, although we don't think of BV as a classic sexually transmitted infection. Also associated with increased BV have been things like smoking or douching, although I would say these associations are a bit mixed and the data is not as strong as you might think. Associated with decreased BV in large epidemiologic studies are the use of condoms, as well as hormonal contraception, although we'll talk a little more about some recent research on hormonal contraception. It's not clear that all forms are equally protective. And then there have been studies that show that male circumcision can decrease BV in female partners. Many women, although not all, will also report either menses or vaginal sex, especially without a condom as triggers. So these are all factors that are associated. But really, why BV is so recurrent is poorly understood. And there are hypotheses that center around two sort of different possibilities. And the truth is probably somewhere in between, or perhaps one is more important than another for certain people. But the hypotheses surround either reinfection/reinoculation or relapse. And by reinfection/reinoculation, I mean the concept that perhaps the woman is treated, but then a sex partner or a fomite, like a sex toy, something like that, is colonized with the BV bacteria. And so every time that woman has sex, then she's reinoculated with the bacteria. There are also questions about whether there are extragenital reservoirs of some of these bacteria. And so that is one possibility, and I think is certainly very interesting. Now, I will say that to date, there have been a number of different male partner treatment trials, essentially treating the male partner with antibiotics to see if that can decrease recurrences in the index woman. And those have not generally panned out, so they really haven't shown much benefit. There are some methodologic issues with some of those studies, and there are some ongoing male partner treatment trials that certainly we hope will have more promising results. But the failure of these trials at least suggests that perhaps this is part of the story, but not all of it, or it's really not the main factor. Another possibility that people think about is the question of relapse. We essentially treat women who have BV with antibiotics that are active against many of these BV-associated bacteria. But is it possible that we're able to sort of knock down the loads of these bacteria but not completely eliminate them? And if there's a little bit left, essentially because of either a biofilm, which again is very controversial whether that actually exists, but biofilm or antibiotic resistance, perhaps once the antibiotic pressure is relieved, those bacteria can come back. I think another big issue is this issue that our tools to treat BV right now are relatively blunt. Basically, we can blast the vaginal microbiome with antibiotics and knock down the BV-associated bacteria. But if you sort of think about it logically, probably optimal would be not only to do that, but also to try to recolonize with those healthier protective lactobacilli. Especially those like Lactobacillus crispatus, which are really good at producing lactic acid and seem to be really protective. Remember, Lactobacillus iners that I mentioned is not as good at producing lactic acid, is actually commonly found, at least in small amounts in BV, and is associated with transitions to and from BV. So these are sort of the central hypotheses, but exactly why nobody knows. Some research, actually this is a study from quite a while ago now from a group in Seattle, that tracked with qPCR the amounts of different key bacteria in an individual who had multiple recurrent episodes over a short period of time. And you can see, this is, I don't know if you can see my cursor, but essentially on the right of the screen here, the first episode at the top essentially shows that when the antibiotics start, and that's depicted by the green line, the BV-associated bacteria, things like Gardnerella, decrease quickly, whereas Lactobacillus iners here stays elevated. And metronidazole, which is the main antibiotic that's used to treat BV, is not active against lactobacilli, so that makes sense. But you can see they decrease quickly, but then they pop back up again very quickly as well. And then you can see in a later episode that Gardnerella vaginalis seems relatively unaffected, at least for quite a while, by the antibiotics. Now, whether, and then of course, the levels in many of these last days go back up again. Now, whether those levels going up again of those BV-associated bacteria are because of reinfection or reinoculation, we can't tell from this study. Now, things that clinicians can currently recommend or do currently recommend to women with recurrent BV, well, there are not a lot of options, unfortunately. And so one thing that clinicians do recommend is considering condom use. Certainly, if they have a female partner, making sure the partner is treated if the partner has BV symptoms also. And in general, clinicians recommend not smoking. That's a good idea for multiple reasons, and not douching. But there's really a lack of robust evidence that that will actually decrease recurrent BV. And the last option really is suppressive antibiotics, and that is an option in our national guidelines that's offered. Essentially, this is actually a study that was done, a randomized controlled trial that evaluated suppression as an option in women with recurrent BV. Essentially, after getting treated with metronidazole, then they got metronidazole gel to place in the vagina twice a week for an extended period of time. And you can see in this plot here that those who got the metronidazole had fewer recurrences than those who got the placebo. It is quite onerous to do this, though, to put something in the vagina twice a week, and many people can get a secondary yeast infection from the antibiotics. Also, once the suppressive antibiotics are stopped, many women will recur. So this is kind of our option, but for lots of reasons, it's not ideal. So that brings us to the last part of the talk and really talking about future directions. Our treatments are not great. Our sort of main option for suppression has a lot of drawbacks and is not completely effective either. So we really need more effective treatments. And so there are some things that people are considering, but none of these are ready for prime time now, or as yet. So one thing people wonder a lot about is, what about hormones and hormonal contraception? Can that play a role in helping prevent recurrent BV? And so we do know that hormones seem to have an important impact on the vaginal microbiome. So as women go through menarche, go through puberty, menarche, and in the reproductive years, as estrogen goes up, lactobacilli tend to go up, and then in menopause, as estrogen goes down, lactobacilli in the vaginal microbiome tend to go down as well. Even within a menstrual cycle, at times when estrogen is high, there tends to be more stability of the vaginal microbiome. Whereas during times of menses, whether it's related to hormones or related to the presence of blood in the vaginal vault, there seems to be a destabilizing effect, and oftentimes this is a time when people's BV may be triggered. So there are a lot of questions about whether hormonal contraception could help with this by sort of either regulating the levels of hormones or potentially by decreasing some levels of vaginal bleeding during menses. And there have been multiple, or there have been sort of large systematic reviews that have shown that both progestin-only and estrogen-progesterone combined contraceptives may be associated with a decreased overall risk of bacterial vaginosis. But I will say that more recent studies have started to call into question whether these really have the same effect and are equally beneficial. So I think what is increasingly clear is that there does seem to be a reduced risk of incident and prevalent BV in users of combined contraceptives, particularly combined oral contraceptive pills that have both estrogen and progesterone. But it's not clear that progestin-only contraceptives have that same positive effect on the vaginal microbiota. Now, I will say there was a small pilot study that was done looking at randomizing women with recurrent BV to get combined oral contraceptive pills versus controls, and didn't really show a benefit, but it was very small, so only about 20 women involved in the arm that got those combined oral contraceptive pills. So I think there are a lot of questions about how hormones might impact bacterial vaginosis. One of the studies we did actually in our group was something called the hormonal contraceptive or hormonal contraception longitudinal study, where we enrolled women who were starting and stopping contraceptives, hormonal contraceptives, and followed them with frequent vaginal sampling over a couple of years. And we did find that those who were using the majority of people in this study who were using hormonal contraception were using combined oral contraceptive pills. We did find that those using those COCs had an increased likelihood of being dominated in terms of their vaginal microbiome by lactobacilli, and there was increased stability in those using oral contraceptive pills as well, as compared to those who are not using hormonal contraception. In a sort of small subset of people who initiated oral contraceptive pills, we found that stability seemed to kick in around a month after starting and leveled off after that. So potentially a role for hormones and potentially hormonal contraceptives. What about menstrual practices? Well, this is something people wonder about. Again, really nothing definitive here, but there was an interesting study done by Mehta, where it was a cluster randomized controlled trial done in Kenya, in Africa, involving 96 Kenyan secondary schools, where secondary school age girls were randomized to either get, it was actually a 4-arm study, but essentially to either get a menstrual cup to use during menses or control. And interestingly, what they found was that the prevalence of BV in those using the menstrual cup was somewhat lower at various time points, while the mean relative abundance of Lactobacillus crispatus was somewhat higher. Though I will show you, I'll sort of point out here that the prevalence of BV in terms of the absolute difference between those two arms, the absolute difference was quite small. So how much difference this, actually makes in the real world is unclear, but it's an interesting finding. And then there's a lot of talk and interest in novel microbiome-based therapeutics. So back in 2020, there was a large randomized controlled trial published in the New England Journal of a Lactobacillus crispatus vaginal probiotic that was given after pretreatment with metronidazole by vagina to women who had acute bacterial vaginosis. And then they got this Lactobacillus crispatus vaginal probiotic for a period of 12 weeks after that. And they did find that at 12 weeks, while they were still on this probiotic, that there was a statistically significant difference in BV recurrence. So in the probiotic arm, 30% of people had a recurrence, whereas in the placebo arm, 45% had a recurrence, although after they stopped the probiotic by week 24, that difference was no longer statistically significant. So I think this certainly raised excitement about the possibility that something like a probiotic could help prevent BV, although this sort of study in and of itself was not that exciting because, a 30% relapse rate is still pretty terrible. There's also been interest in an interesting concept of vaginal microbiota transplant. You've heard of FMT for C. diff diarrhea or C. diff colitis. There's been some research and there's some ongoing research from a variety of groups in different places on the idea of vaginal microbiota transplant for women with recurrent bacterial vaginosis. And I will say there's very little data so far. This was one study published with only 5 participants. It wasn't exactly a slam dunk, but there seemed to be some benefit for some of these individuals. So this is something that people are investigating. I think not necessarily so much as a planned, therapeutic option long term, but in part really to understand what we can learn about the pathogenesis of BV from these kinds of studies. So really in terms of future directions and challenges, I think the real question for the future is our current understanding of BV and recurrent BV is imperfect. And certainly our current therapeutic options leave a lot to be desired. So I think the real question is, can we really further develop our understanding of the pathogenesis of BV and recurrent BV? And then can we develop vaginal microbiome or sort of microenvironment-based therapeutics to treat and prevent symptomatic BV and recurrent BV, as well as potentially to prevent things like urogenital infections, STIs, or improve obstetric outcomes in women? And so some of the things that we talked about that are being thought about, although again, none of them is ready for prime time, are things like, is there a role for hormones, menstrual measures, menstrual hygiene measures, sort of live biotherapeutics like probiotics? Are there options where we can actually inhibit key BV-associated bacteria or conversely enhance the growth of healthy bacteria like lactobacillus or lactobacillus crispus? But there are a lot of challenges here. I think one of the main ones is, again, our imperfect understanding of the pathogenesis of recurrent BV. I sort of mentioned that right now we treat every woman with BV the same because we don't have the ability to do anything else. The only option we have is antibiotics, and really only 2 kinds of antibiotics at that. But BV may not be the same for every patient. The vaginal microbiome may not be the same. The interaction with the host may not be the same. And so really, do we need to look towards the future of something more like personalized medicine, where we can find the right treatment for the right woman? I think that's an open question. I think it's been a real challenge to affect a stable, long-lasting optimization of the vaginal microbiome. You can see from the probiotic study that I showed you that very quickly after stopping the probiotic, the sort of even modest benefit that was achieved went away. And then what is really the effect of our treatments on the woman and on markers of inflammation, for example, when we're trying to, what we think is optimize the vaginal microbiome, is that really the most healthy thing, or are there potential unexpected side effects that could result? So a lot of challenges in the future of this field. So just as a summary, back to the patient's questions, what is BV? We think it's a disorder of the vaginal microbiome characterized by a relative lack of lactobacilli, but beyond that, it's quite mysterious. Why does it keep recurring? Well, it's really unclear, although we're thinking about reinfection versus relapse. What can I do to stop it? Well, our current options are not the best. Clinicians can recommend considering condom use or suppressive antibiotics, but as we mentioned, there are downsides to that. So really the future is understanding more about BV and recurrent BV. We need more research to do that, and then ultimately, based on that understanding, to develop better treatments. And perhaps some of the directions would be things involving hormones, involving menstrual hygiene, involving sort of live biotherapeutics or particular ways to affect specific components of the vaginal microbiome. But I think the field is wide open, and hopefully some of you will participate in that research in the future. So I think I'll stop there. These are some of my acknowledgments, and I'd be happy to take questions. And Israel,
Susan,
I don't know if I'll be able to, yeah, go ahead. Go ahead.
Oh, no, you're fine. Thank you so much for that presentation. We actually do have quite a bit of questions. Susan, on your screen, if you'd look on the very left-hand side, you should be able to see them. But I'm going to go ahead and read them off to you so you can answer. And to our audience, feel free to continue to ask questions. We do have ample amount of time for these. So let's go ahead and dive into this first question here, which is the vaginal microbiome similar to other microbiomes in the body? And does a disorder of the vaginal microbiome affect other microbiomes in the body?
Well, that's really interesting. So it's a fascinating question. So the vaginal microbiome is incredibly distinct, actually, very, very different from the other microbiota. And just as an example, the vaginal microbiome is really completely distinct from the gut microbiome, even though we'll just say that, sort of geographically, those two are located in very close proximity to each other. But it's just fascinating that they are so different. And so the gut microbiome is much, much, much more diverse than the vaginal microbiome. There are many more different kinds of bacteria that are present. And also, what characterizes health is completely different in the vaginal microbiome as compared to the gut microbiome. So in the gut microbiome, it's really very unclear, but most studies have found that diversity and having a very diverse microbiome in the gut is associated with health in a variety of almost any condition you can think of. Whereas in the vaginal microbiome, it's the opposite, right? We call diversity bacterial vaginosis, and it seems to be a bad thing. So the short answer is they're very distinct. Now, can disorders of the vaginal microbiome impact other microbiota? I think that's a good question. Not clear that that's the case, although there's a lot of questions about whether the reverse is true, particularly when people are thinking about interventions, right? Because something that a lot of people think about is probiotics. Now, probiotics could be given vaginally, but much more commonly, probably most of the things you can buy over Amazon or at your local drugstore, those are oral probiotics. And so there are a lot of questions about whether if you take an oral probiotic, like take a lactobacillus by mouth, and that goes into the gut microbiome, is there a possibility that can positively impact the vagina? And I would say the research is not great on that. There have been a variety of sort of mixed small studies that are not well controlled, and some of them might show some benefit, others don't show much benefit. Certainly none of the, there are many, many, many sort of probiotic products out there, but there's just not good evidence for those helping, though I think in the long term we hope to have sort of scientifically proven rigorous options like probiotics that could help women with BV. All right, next question.
Sure thing. Thank you for that. Our next question is, how does pregnancy impact the vaginal microbiome and the reoccurrence of BV?
So that's very interesting. So pregnancy does, we think, have a significant impact on the vaginal microbiome. Really, the details of that, there's a lot of research ongoing on that. But it does seem that pregnancy, potentially because of very high levels of particular hormones, seems to, in general, stabilize the microbiome and seems to push it towards a lactobacillus-dominated state. So yeah, there's a very sort of important impact on the vaginal microbiome. Exactly the degree to which that impacts recurrent BV. Of course, there are still some women who are pregnant who get BV and symptomatic BV. I don't think we have great data to suggest, if a woman with recurrent BV gets pregnant, what percentage of the time will her recurrent BV improve? But I think it's a good question. Next question.
Absolutely. What, in your opinion, are the most promising areas of future research into BV and the vaginal microbiome that could improve patient outcomes?
Yeah, so I think it's a great question. And I think, there are a lot of other, areas of research. I tried to highlight a few that I think are potentially important. But I will say that I think, though I don't know, but I think that most likely it's going to be not necessarily just one thing is that develops into that one magic bullet that will fix the problem for everyone. But I suspect it's going to be a combination of things, and that you might get sort of an incremental benefit from a variety of different interventions, but perhaps you have to combine them. And perhaps it's also going to be tailored to the individual woman. So, for example, maybe in particular people, that partner factor is really important. And in other people, it's less important. And perhaps, we get some incremental benefit from something like a probiotic, but that really needs to be enhanced by choosing the proper pretreatment or something adjunctive to give with it. So I think the short answer is I tried to highlight some areas that I think are promising, but I suspect that it's not going to be just one thing that sort of solves all our issues. I suspect that we're going to need a combination of things and that those things may not be the same for every person. Next question.
Understood. Yeah, thank you for that. Our next question is, dysbiosis of the microbiome in other areas of the body have been linked to certain disease states, like the oral microbiome and periodontal disease / cavities. Are there any links to BV and disease of the vagina?
Right. So I apologize if I misinterpret the question, but I think what the question is asking is, are dysbioses of microbiota in other anatomic sites linked to BV or diseases of the vagina? So I think I mentioned there isn't actually a lot of research on this. There is a little bit of research into whether extragenital reservoirs of certain bacteria may impact the vaginal microbiome. So whether that's BV bacteria that might be hanging out, say, in the gut microbiome, and aren't completely eliminated by antibiotics that are given for BV, and then that's a source of, BV that can recur, or whether that is questions about healthy bacteria like lactobacilli, and if you have lactobacilli in the gut, can that actually affect and potentially improve your chances of not having a BV recurrence? I think those are questions, but there's not a lot of data on that. I will say there is research, for example, on things like preterm birth, and there's research both linking potentially inflammation as a result of, say, periodontal or perioral disease and a preterm birth outcome. And there's also research potentially linking the vaginal microbiome to things like a preterm birth outcome. And, preterm birth is something that is very complicated and probably multifactorial. So, are those both related to preterm birth and not related to each other, or is there some relationship to each other? I think nobody knows for sure, but it's certainly something that people are starting to try to look at, although I don't think it's an area that has a lot of research. Next question.
Sure thing. Our next question is, which approaches are preferred for analysis of the vaginal microbiome? Amplicon short-read 16S sequencing and or Amplicon long-read full-length 16S, or shotgun metagenomic approaches? Another part of this question is, and does one ensure consistency of sampling and sequencing when following patients longitudinally?
Yeah, so I think in terms of the preferred methods, well, I would say that the backbone of most research has been using Amplicon sequencing with the V3, V4 region, 16S Amplicon sequencing with the V3, V4 region, or sometimes just the V4 region. So I think that's what most of the research has used, I think historically at least, in part because of cost. As costs are coming down and our techniques are improving, I think more and more now people are really doing metagenomic, shotgun sequencing to look at the vaginal microbiome. And I think there's some disadvantages and advantages. So statistically speaking, when you have when you do metagenomic analysis, the output you have is somewhat more complicated. And so, for example, there are ways to group the vaginal microbiota of women into CSTs, but we tend to call them MG-CSTs, metagenomic CSTs, and there are many more of them. So on one hand, I think it provides a much more in-depth look at the vaginal microbiome with a lot more detail, and potentially a better opportunity to look at things like functional or predicted functional capabilities of the vaginal microbiota. So it's valuable from that respect. I will say it also comes with challenges because often you're trying to, we're still doing a lot of really foundational, sort of fundamental research. We're trying to see if we can relate certain microbiota features to certain clinical features or outcomes. And doing that when you have many different things to look at can be challenging from a power and statistical standpoint. So I think most people are moving towards metagenomics because of just being able to look with a lot more specificity and detail at the vaginal microbiome, but it has its own challenges. Next question.
All right. We do have a little bit more time for questions if anyone from the audience would like to submit. But we do have one last question here so far. This last question here is, what is your thought on aoronic vaginitis, or AV, in women? And forgive me if I'm mispronouncing that. Followed up by, what is your view on co-infection with AV and BV and its likely role in recurrent infection, as the BV treatment likely does not treat AV?
So I think what's meant here is actually aerobic vaginitis, not aoronic vaginitis. So I will say this is a very controversial condition, and I think it's certainly an area that probably needs more research, because I think there's a lot of question about the extent to which aerobic vaginitis is a true entity, whether it is actually pathologic or relates to symptoms. And I think many clinicians are pretty skeptical of that. And I would say, I think that the evidence about exactly what aerobic vaginitis is or isn't, and the degree to which it causes symptoms or doesn't, is poor, or at least not very robust. And so I think that it's not a condition that is very well accepted in general in the clinical community. And I think that's sort of what I'll say about that.
Perfect, thank you.
Next question.
We did get
I think there was a follow-up question
that
was, is dysbiosis of the vaginal microbiome? Yeah, go ahead.
No, that's actually great. If would you like to talk on that? So sorry, I should have been more specific. So since dysbiosis of the vaginal microbiome linked to, say, higher occurrences of things like cancer and other conditions, but yeah, feel free to speak on that.
Yeah, sure. So yes, there is, again, I think, a burgeoning area of research, particularly focused on the vaginal microbiome and HPV. So human papillomavirus, as you probably know, is actually the most common sexually transmitted infection, and it can lead, in particular, if persistent, to cervical cancer. And there is, again, I think, an emerging area of research suggesting that features of the vaginal microbiome, again, sort of that, BV state, or that low lactobacillus state, seems to be linked to an increased risk of both incident and, importantly, persistent HPV, or human papillomavirus, in the urogenital tract. And then there's a lot of interest in, how that may relate to cancer, including things like cervical cancer. So I think it's an area that is certainly of a lot of interest to many people. And there's at least some initial data to suggest that there may be some relationship. There's also a lot of interest in the role of the vaginal microbiota in susceptibility to a variety of different infections. As I sort of mentioned briefly in the talk, BV is very interestingly related to an increased risk of acquisition of really essentially every sexually transmitted infection you can think of: gonorrhea, chlamydia, trichomonas, HIV for sure. And as I also mentioned, even people who don't have BV, there may be differences in susceptibility based on which kind of lactobacilli they have, with some lactobacilli being more protective. There's also a lot of interest in relationships between vaginal dysbiosis or bacterial vaginosis and adverse pregnancy outcomes, because that is a huge problem in really globally, not just in the US, but many, many places. And there are a lot of questions about BV's relationship and the vaginal microbiome's relationship to things like preterm birth or other bad outcomes. And there's also a lot of interest in the relationship of the vaginal microbiome to infertility. Is there a relationship there? That's an area that people are certainly researching. And I think a lot of the interest in being able to treat BV and being able to prevent recurrent BV centers around women's symptoms, right? Because BV can cause vaginal odor and discharge, and it's really a big problem for people and really impacts their quality of life. But there's also a huge proportion of the research that is very interested in the question of really, can you affect the vaginal microbiome, then not necessarily just to treat and prevent the symptoms of BV, but prevent the larger consequences, like that increased risk of STI acquisition or that increased risk of adverse pregnancy outcomes. And because we found that, whether people are symptomatic or asymptomatic, they have an increased risk of those things. So I think it's a fascinating area, and I hope that in the long term, although there's very little ready for prime time as yet, I hope that in the long term we can really learn things and develop interventions that can help improve reproductive health and obstetric health.
All right, Susan. Well, that brings us to time. So thank you so very much for presenting today. And thank you to our audience for all of your interesting questions. Questions we didn't have time for and those submitted during the on-demand period will still be addressed via the contact information you provided at the time of registration. This webcast can still be viewed on demand for 1 year until September 5th, 2025. And LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Also, feel free to continue exploring this incredible virtual space, including the exhibit hall, where you can check out our exhibitor booths and even speak with their representatives, and also the LabRoots store, where you can pick up some cool science merch. Thanks again to our audience and to you, Susan. Goodbye, everybody. Thank you.
Thank you.